Hello, everyone. Today we are welcoming back Dr. Lindsay McAlpine. Lindsay was here for the Kindred Cafe in July, and she has kindly offered to come back and answer a few more of the questions that were in the chat. Dr. Lindsay McAlpine is a neuroimmunologist and an instructor in the Division of Neurological Infections and Global Neurology at the Yale University School of Medicine. She started the NeuroCOVID Clinic at Yale in October 2020 and sees patients with neurological issues related to long COVID. She is an investigator in the COVID mind study at Yale, and her research interests are related to the pathophysiology of cognitive impairment after COVID-19 using several modalities, including MRI. A question for Dr. McAlpine, if there is time. Can small fiber neuropathy resolve over time, or is it permanent or progressive? What are some of the theories behind this common long COVID, long vax symptom?
Yeah, so I think that's an important question because so many patients with long COVID are found to have small fiber neuropathy. So the first, does it resolve over time? In a lot of cases, it does resolve, and in other cases, it doesn't. Usually there's a complicating factor when it's not resolving, like diabetes or prediabetes can be another reason to have small fiber neuropathy, another disease that's damaging and affecting the nerves. Is it permanent or progressive? After COVID, in my experience, it is worst at onset. So it's the worst right after the infection, usually comes on within 1 to 6 weeks after the infection, and that's the worse it gets. It doesn't usually progress unless you have another inflammatory influence causing progression. And what are the theories behind this? So one of the theories is that there is, during the acute infection, there's such significant inflammation that's triggered that it damages the small fiber nerves. The exact mechanism of the damage, we're not sure. Is it molecular mimicry? So do the small nerve fibers to the immune system look like the virus and therefore cross-react? That's one of the thoughts. But what we think it is, given the time of onset, post-viral autoimmune conditions almost always happen within the first 1 to 12 weeks after a viral infection. And so because it comes on in that window and is maximal at onset, it makes sense that it's an autoimmune condition that's triggered. And often we see that there are also autoantibodies that are developed, like I mentioned during the panel last time, that the University of St. Louis or Washington University in St. Louis has an excellent panel that tests for some autoantibodies that are linked with small fiber neuropathy. And, that addresses one of the other questions that when you have an autoimmune disease, every time you get a viral infection or any infection really, you can have worsening of your autoimmune symptoms because you're turning on and turning up and revving up the immune system, and that's going to rev up your autoimmune disease. So one of the other questions was that they got worse during viral infections after this. That makes a lot of sense.
Thank you so much. Next question is related to migraine and headaches. A recent appointment with an ME/CFS practitioner, it was proposed that the initial long COVID symptoms were atypical migraine, that after persisting caused POTS a month later and all the other symptoms. My husband has been bedridden since the fall and extremely severe at this point. Does the explanation of untreated persistent migraine track?
So I think that in some individuals that untreated migraine is definitely contributing to long COVID. We've seen an increase in new migraines after COVID, and also an increase in severity of migraines after COVID in people who have already had migraines. So as a neurologist, we call almost all headache migraine because it is mediated through the same trigeminal ganglion, which mediates pain in the brain. So I don't think that migraine is an explanation for all of long COVID. It certainly is commonly comorbid with some of the conditions that come on after COVID, like POTS. POTS and migraine can be linked. Same with, Ehlers-Danlos or chronic fatigue, or mast cell and migraine are closely linked. So there's a connection, but I don't think it's the entire explanation. And so treating each of those individual conditions is what is going to kind of remove the roadblocks to recovery, and making sure that each migraine is treated effectively is very important. You want to treat a migraine at the very onset of the headache before it ramps up into a major painful attack. Some of the other questions include head pressure and pain at the back of the head. So we've seen quite a bit of occipital neuralgia. So the occipital nerves comes out of the neck and it comes through the neck muscles, and tight neck muscles pinch the occipital nerve. And then it causes this numbness, tingling, pain in this distribution on each side. So we've seen that quite frequently as well. And then there's a question here about what's headache and what's migraine. So I think we call almost everything migraine. Typically, a migraine can be associated with a bunch of other symptoms. So migraine can be associated with sensitivity to light, sensitivity to sound and smell. You become sensitized to everything. It's associated with nausea because migraine involves the vagus nerve, which slows down, causes some gastroparesis as well. And it also can be associated with neck discomfort, neck pain, irritability, word finding difficulty. What else? Specifically aura as well. So visual aura, sensory aura can all be involved. And so migraine is a syndrome. It's just not it's not just head pain. Next question.
Next question is, any suggestions for screen sensitivity? Since COVID, I have developed atypical trigeminal neuralgia and feel like I am in a sci-fi film. Looking at any screen through my right eye sets the entire left side of my face on fire, even with my left eye closed. Incredibly debilitating, can't work, hard to function.
Yeah, so I think when I was looking through a lot of the questions, I think this is really important because not everything that comes on after COVID is long COVID. So a lot of patients have other conditions that come on after long COVID. So I would call new trigeminal neuralgia, that's trigeminal neuralgia. We're not going to treat it any differently because it came on after COVID. And I wouldn't put it in that bucket of long COVID either. And I think that's important because you want your physicians, your care team, to treat that condition like that condition, no different because of COVID. And so trigeminal neuralgia is a really painful, uncomfortable, awful condition. I'm sorry that happened. And there's a lot of different therapies you can try. Making sure you get a full workup with imaging and everything is really important. And then going through, just like any condition, it's important to try each thing and see what works for you, because it's going to be different for each patient. One of the other things is that, seeing patients with Guillain-Barré syndrome, which is a distal progressive numbness, tingling, and weakness that develops, that is going to come on. We do see it after COVID. We do see it after the vaccines. We see it after any viral infection or vaccine. It has reports. And it's an autoimmune attack of the myelin on the peripheral nerves. And so it's triggered by the infection, and then it comes on within a few weeks after the infection. And so if you're kind of falling into that long COVID bucket of after 3 months, then it's not going to be related to Guillain-Barré, and it has a very classic symptoms and timeline too. So one of the other questions is a patient wrote in about being diagnosed with transverse myelitis, and again, I would say transverse myelitis can be triggered after COVID or after a vaccine, but I would not call it long COVID. It's transverse myelitis. It has its own set of workup, has its own set of treatments, and I wouldn't consider that long COVID. Let's see. And same with the GAD65. GAD65 is an autoantibody that develops and it causes stiff person syndrome. So one of the patients said that was positive in both their blood and their spinal fluid. And so I would say to that, that's, probably early stiff person syndrome, and that warrants a full workup and treatment. So disease modifying therapy, and close monitoring with a neuroimmunologist. And so I would take that approach. When I see a patient, I'm always making sure that we're not missing something else. We're not missing another disease and just lumping the symptoms in with a bucket of long COVID, things that aren't long COVID. Yeah. Next question.
Thank you. That's a really important distinction.
Yes.
Next question. Can you briefly mention the theories of what causes persistent neurological COVID symptoms and what traction each has, e.g. autoimmune reaction, persistent virus, viral remnants, etc.?
Yeah. So I have a slide. So here is a figure from the publication Science by my mentor, Dr. Serena Spudich, and one of our colleagues at the NIH, Dr. Avi Nath. You can see here that it kind of reviews the mechanisms of effect. And so starting generalized neuroinflammation with trafficking of immune cell cytokines and autoantibodies into the brain and activation of the microglia. We know this happens during the acute infection, but once the immune system is kind of turned down, to what extent is this persisting? We're not seeing ongoing cytokine elevations in the spinal fluid. And so it's unknown the extent of the persistent neuroinflammation, particularly in the absence of objective, clear inflammatory lesions on MRI. We're not seeing that. So we're not seeing the vast majority of people with long COVID have completely normal clinical MRIs. Antibody production within the spinal fluid in response to the virus and autoantibodies. We've published on this. We found unique autoantibody signatures in the spinal fluid. We've also found autoantibodies to COVID in the spinal fluid. And a portion of that is probably leaking over from the bloodstream into the spinal fluid and may or may not have a clinical effect, because we see elevated antibodies in both our control subjects with no long COVID and in our long COVID subjects. So it's unclear. So there's limited, evidence for the presence of actual viral particles or proteins in the brain, very, very limited. So I think this is an unlikely scenario here. The blood vessels is my main focus of interest. They may be damaged or dysfunctioning due to endothelial activation, which is the lining of the blood vessel, and this cascade of coagulopathy, and in some cases leading to microbleeds or stroke, particularly in the acute infection. This is not seen as frequently in long COVID. So after 3 months after the acute infection, we're not seeing strokes or bleeds in the brain. But when we talked about before the dysfunction of blood vessels and withdrawal of oxygen from the tissues that occurs in chronic fatigue syndrome, where the blood that's going through the tissues, a chronic fatigue patient is only extracting half, 50% of the oxygen, and an individual without that would extract 80%. So that dysfunction of the diameter of the blood vessels and shunting at the tissue level may also be happening at the brain. So that would explain why there is such exquisite sensitivity. So the brain is a very sensitive organ to any dysregulation or disruption in function. So even if there's a little bit of disruption in the function of the blood vessels in the brain, I would expect there to be symptoms from that. And so that's my theory, but I have no proof for this. There is some preliminary evidence out of Harvard that there is cerebral hypoperfusion, and I think this all goes on the same spectrum. And what we're not seeing is objective frank strokes. So that is the good news. So there's subtle dysfunction, but no severe lack of oxygen to the brain.
Thank you so much.
Yeah.
Next question. Are there reliable tests available here in the US to diagnose microclotting?
We addressed this a little bit at the last meeting, but we haven't found clear evidence of microclots, actual clots in the tissue and the blood vessels. It's more the activation of the endothelial lining and subtle persistent vascular inflammation. There's a number of clinical blood tests that can tease this out. One of them, I'm trying to think of, a lot of them are research tests. C-reactive protein can be a very general marker of inflammation of the blood. Elevated von Willebrand factor has been shown to be elevated in acute COVID linked to endotheliopathy. There's a number of different markers that can be used both in research and clinically to tease this out.
How are you diagnosing the vascular inflammation you described?
Right. So it's in the blood, we're using research tests, and in the brain, we're using also research tests, sequences to look at subtle perfusion differences in the brain. Yeah.
Next question. Do you have an experience opinion about HBOT following up on the theory of poor oxygen at the micro level?
Yeah, so there have been some small promising studies that show that HBOT can improve fatigue and some of the neuropsychiatric symptoms of long COVID. I do think it's related to this chronic fatigue pathology, so the dysautonomia pathology. The one issue is that in patients who undergo HBOT therapy, it improves while they're on it, which is, a time-intensive therapy. But once it finishes, it doesn't seem to have a lasting recovery effect like the dysautonomia PT exercise protocols do. Yeah. And then, one of the other thoughts is with severe fatigue, it's also important to look for those other things. So we'll talk about sleep next, but making sure that everybody has a cortisol test, making sure that there's no adrenal insufficiency. That's really important. And then there was another question here. I think it's important too. A lot of patients come to me really wanting to know, was it COVID that caused my post-viral syndrome, or was it something else? And I know that a definitive answer would be helpful, would make patients feel better. But from my perspective, it doesn't matter because this condition, post-viral syndrome, can happen after anything, right? So it can happen after mono, CMV, GYN infections, the flu, parafluenza, can happen after any inflammatory viral illness. And so I would say take what you have and what symptoms you have and focus on how to heal and get better. And that answer is like something we can't always provide and won't necessarily change your treatment, if that makes sense. Yeah.
Have there been patients post-COVID who you have sent for further evaluation for narcolepsy or autoimmune encephalitis?
Yes.
Sorry.
Encephalitis. Yeah. Yeah. So we've seen, and there were quite a few questions about sleep. We've seen a lot of sleep disorders after COVID. People seem to be much more sensitive to sleep deprivation and interruption after COVID. One of the first things that I do for anyone with sleep issues and cognitive issues is to send them for a sleep medicine evaluation with a sleep study. That's really important. We are finding a lot of new sleep apnea after COVID. I don't think COVID necessarily caused that, but it's just now you're going to have many more symptoms from it. You're not going to be able to tolerate it well. And so sleep apnea is treated, whether it's central or obstructive, it's treated very similarly with a CPAP. So the continuous positive pressure machine overnight. A lot of patients balk at that, understandably so, but it improves the quality of sleep and the quality of life so much that almost everybody who gets it loves it. They take it everywhere. Vacation. If they have to come to the hospital, people bring their own machine. They love it. So I really encourage all of my patients to give it a try, to pursue the full workup, get treatment for sleep apnea. And then I've had patients convert their entire family, get their entire family diagnosed and treated, and everybody feels a lot better. So I think that's a really important thing. Getting treatment for insomnia, really important too. Treating the underlying anxiety or depression that might be contributing to insomnia. The gold standard therapy is cognitive behavioral therapy, a type of psychology approach. It's wonderful. We have a wonderful team here that does CBT for insomnia, and my patients love it. It's a really healthy approach to sleep, and it gives you the coping tools to manage insomnia. Some of the medicines that I'll use, one sec. For insomnia, one of the ones I use the most is probably trazodone. It's well tolerated, lower doses, not habit forming, and generates sleepiness. In addition to that, all of the sleep hygiene things. So no blue light, no screens, cool bedroom, wind down before bed. It's all of the lifestyle factors are so important. We can put medicine band-aids on top of them, but if we don't change the underlying health, create a healthy lifestyle, it's really hard to medicate over that.
Hi, I got the COVID shots. I have stomach issues since I got the shots. Now I have tics going on. Plus, this month alone, I was plus stutter. I was in the ER on July 9th.
Yeah.
Plus I stutter.
Yeah. So stutter and tics. Yeah. It's COVID itself can cause new psychiatric issues, anxiety, depression, panic attacks. I've had patients who during their acute illness were, suicidal and never been suicidal in their life. Like there is objective evidence that it does alter the function of the brain. And then the experience of long COVID is so difficult that it's not surprising that people in reaction to the difficult experience develop anxiety, depression, and other psychological disorders. I've seen it a lot, new tics and stutters. Sometimes people with stutter will have had it as a kid and then it comes back after COVID. Sometimes it's as a stress response too. I think one of the other participants mentioned developing somatic symptom disorder, which is basically excessive anxiety about, physical symptoms in their body, which again is an understandable response to having so many symptoms, developing long COVID. There's such an interplay between mood, cognition, sleep, function, all well-being, that you really can't tease those things apart. And so I really encourage all of my patients to address all of the psychological issues, because they can be a big roadblock to healing and to feeling better. Because no one, well, I'm not, and certainly no one in our clinics is saying that any of this is in someone's head, but the suffering in your head can make your symptoms and make you feel a lot worse. And so I really encourage all of my patients who are struggling to get the help they need with therapists, psychiatrists, sometimes going on a medicine for 6 months to a year while you're going through this really struggling, this difficult time while you recover. It's not forever. I think it's really, really important. And on the same vein, I have seen quite a few patients with functional neurologic disorders, which is where neurology and psychology really kind of overlap and come together. Functional neurologic disorders are basically, they're not volitional. Patients are not doing these things on purpose. There's no awareness that this is on purpose. It's not on purpose, but it can come in many different ways. So it can be new tremors of they're very distinct characteristics. So it's hard to describe, but tremors, seizure-like events, lower extremity weakness, trouble walking. These are all common ways that functional neurologic disorders develop. And these things develop in response typically to stress. The way that we describe it is it's a dissociative disorder where your mind and your body's experiencing stress, depression, anxiety, and it's difficult to cope with. Your subconscious doesn't know how to deal with it. And so this is how it comes out. It comes out as a new tremor, comes out as kind of complete dissociation, seizure-like events. It comes out as difficulty walking. And so, the number one thing for getting better from a functional neurologic disorder is insight, really insight into, oh, yes, this has been really hard. I have not been feeling well. I've been dealing with so many other symptoms and issues. It makes sense that, I'm having a hard time. And one of the treatments is also cognitive behavioral therapy. So using relaxation and coping methods to address the psychological issues. So we've seen that a lot in conjunction with long COVID too.
Thank you.
I do think, another question when it comes to like the somatic symptoms is, a lot of people have said they've had so much workup, they've had so many tests and they're all normal. In this condition, we expect them to be all normal. You may have a positive tilt table test from POTS. If you're lucky enough to get an invasive CPET, that would be abnormal. But we expect the MRI, the lab tests to be normal. And if you've had a thorough workup for all of the symptoms that you have, then usually I say to my patients, we can stop looking and focus on recovery. So I think that's like a really hard balance, is when to know when to stop going down the diagnostic pathway and turning to the healing recovery pathway. So, working closely with your doctor to kind of figure out where that line is, and then moving ahead with the therapies and the treatments that work. Yeah.